Thank you. I, again, am extremely pleased and excited to be here. First trip to Atlantic City. I'm not sure what it means when they ask me to give this talk on MACRA and I follow a provider-ordered life-sustaining therapy talk. I'm not sure what that means for us. I have been very impressed over the past couple of days that when I mention MACRA, and as was mentioned before, the Medicare Access and Children's Health Insurance Program Reauthorization Act, Public Law 114-10, that I get a lot of acknowledgement. You know about it. You've heard about it. Unfortunately, in other areas that I've been to, other parts of the country, I'll mention MACRA, and this is sort of what I see. And we are not, you do not want to see me do the Macarena. I don't dance, and that would not be a pretty sight. So if we look at our current state, where we are in fee-for-service, volume over value, silos of care, overutilization, we've been there, we've lived there, and there is no doubt that we've been talking over the past 10 years. We're moving towards paying for value. We're moving towards paying for value. And we really haven't seen much of that. I will say, though, that then Secretary Sylvia Burwell for CMS several years ago really came out and boldly said that we want to move towards a value-based payment system. And she put goals on there to say that by the end of 2016, have 85% of Medicare payments tied to quality or value, and to have at least a third of those through some sort of alternative payment model, as well as pushing the commercial payers to say by the end of 2020, let's have 75% of your payments through a value-based arrangement. So we all know that the goal of MACRA is to repeal Medicare SGR. And I want to just point this out because we're going to get to this in just a little bit later in the talk. To strengthen Medicare access by improving physician payments. So what is MACRA? Well, it was signed into law a little over a year ago, April 16th. It was passed overwhelmingly with bipartisan, bicameral support, and it repeals the SGR. And we don't need to go into the SGR. We were all there. We all had our call to actions. We fought with it for 12 years. It extends the CHIP program funding through the end of 2017, and it creates two payment pathways that we're going to talk about in a moment. It does provide for an annual baseline fee schedule update this year through 2018 of 0.5%. It was, again, enacted after President Obama signed it into law on April 16th. The request for information went out on the law in October of last year. The AAFP turned in their 58-page information letter on November 9th, so it's on the website if you care to read that. But that was the law. We've been waiting for the rule, and the proposed rule, all 962 pages of it. Everybody raise your hand if you've read the entire thing. Good. It was released on April 27th. The 60-day comment period is fast approaching, and your academy has a 128-page response on the proposed rule. It's in the final edits and ready to go in. Once that is submitted, that will be released. There'll be an executive summary of that that'll be posted on the website. It'll be in AAFP News or one of those venues, so you can see the Academy response to what we're seeing. Initially, the final ruling was recommended or was thought to be out in November, but CMS has actually moved that up. They're really shooting for late September, so sometime around the Congress of Delegates to maybe the first week of October is when we're really expecting to see the final rule. So there should be quite a bit of discussion at that time around that. So if we look at what does this do, it creates two payment pathways. One is a fee-for-service based pathway that will consolidate all of the existing quality programs that are there and put you through the Merit-Based Incentive Payment System, or MIPS. And there's also a pathway for an Advanced Alternative Payment Models, or Advanced APM, where you have the potential to get up to a 5% bonus from 2019 through 2024. Now, when they brought out the law, they talked about APMs, Alternative Payment Models. And then they released the proposed rule, and now they've introduced this concept of an Advanced Alternative Payment Model, which quite honestly caught, I think, everyone by surprise, because there was no inkling now that they were going to have this differentiation. The alternative payment models have been defined by CMS. We're going to talk about those in a moment. But just being in an APM, so think PCMH certified or recognized by NCQA, that in and of itself does not necessarily put you into the APM pathway for the bonus. It's recognized and actually is called out by CMS in the proposed rule, but unfortunately, unless you have additional criteria that we'll talk about in a moment, you're still going to have to participate in MIPS. The advanced APMs are defined. You have to meet additional eligibility requirements that we're going to go over, but you do not have to participate through MIPS. So let's start first with MIPS. So it consolidates all of our existing alphabet soup of quality and value programs, puts it into one composite performance score. There's going to be 4 categories, and that composite score is going to be on a scale of 1 to 100. It does provide an opportunity for payment adjustments, and if you're an optimist, you say it could be positive, and if you're a realist, you say it could be negative. So it takes our existing programs, the PQRS, the value-based payment modifier, and meaningful use, and actually puts those together, and it adds an additional program to that, clinical practice improvement activities. So when we talk about the quality, that's PQRS. Now right now when you submit to PQRS, you're submitting 9+ metrics. It's going to decrease those down to only 6 metrics that you're going to have to report. One of those metrics must be, however, a cross-cutting metric, meaning something that crosses all practice sites and all venues. Things such as poor hemoglobin A1C control, medication reconciliation, influenza vaccines, pneumovax, tobacco cessation counseling, BMI. Those types of metrics, one must be that. And this is for all physicians. This isn't just for primary care. So our urologist colleagues are going to have to report on one of these as well. The other 5 of the quality metrics can be specialty specific. Resource use, that's your value-based modifier. And really that's looking at your QR, your quality and resource use report card. Has everybody heard of that? Has anybody looked at theirs? This is really right now, this year, as part of the value-based payment modifier, we're all going to be on the line for up to 2% increase or decrease based on this resource use. So it's being tracked on us right now. Most physicians around the country are neutral, especially primary care physicians. Some groups are negative, a few have been positive. But it's information that's out there now, and that's going to be where our resource use is going to be one of the factors that it's going to be looked at with that. Advancing care information is meaningful use. And meaningful use, in spite of what Interim Secretary Slavitt initially came out and said, oh, we're going to get rid of meaningful use, and then a week or 2 later put in his blog, well, whoops, I made a mistake, hold on, we're not really. The bottom line is meaningful use in one form or another is still going to be with us, and it's going to be part of the ACI. Now, clinical practice improvement activities, this is the final category. We don't have anything like this right now. But these are going to be things that we're going to have to report on around access, population management, care coordination, beneficiary engagement, patient safety. You can read those up there. Those are going to be the metrics. Well, what does that look like? That looks like what we do in PCMH. But remember, This isn't just primary care. This is going to be for all specialties. They're going to have to be reporting metrics around that. And so that's there. It certainly gives the MIPS a bit of a primary care slant, at least out of the gate, because these are things that we're already currently doing. So when we look at where are we going to be in the first year, and this is in 2019, 50% of your composite score is going to be made up of the quality measures, PQRS. 10% is going to be related to cost. The clinical improvement activities will represent 15%, and meaningful use or advancing care information will be at the 25% level. But that's just for year one. And if we look moving forward, quality starts to go down in terms of the amount of the composite score. Resource use goes up. Your advancing care information and your clinical practice improvement activities stay the same. And so this is a not so subtle statement by CMS as the change agent for us here. Because if I was to ask anybody in this audience, what is the definition of value? It's quality over cost, correct? And if we look in 2019, quality over resource use, quality over cost. But look what happens by 2021 and going forward. It's really, some would argue, that CMS is trying to change the value equation, change it to quality plus cost, or in some cases, even try to make a push for cost over quality. So this is a very definite shift in the way that we think about payment and that the way we're going to pay moving forward. Now, there is something that if you look in MIPS and if you look at, you talked about a primary care bent, what do you mean by that in terms of the MIPS overall scoring? On the clinical improvement activities, if you are in a certified PCMH home, and right now in the proposed rule, what's called out is NCQA, URAC, and Joint Commission. So if you have a current recognition in one of those PCMH models, you receive all 15 points automatically. You don't have to turn any metrics in. That's there. If you are an APM, say, in an ACO, you will automatically get half credit, and you'll have to submit for the rest of the credit. So again, it's not like they gave us a total pass, but at least in one category, if you are participating in a PCMH, that does give you 15 points on the 100. So the annual performance threshold, it's going to be established by the Secretary for 2019 and 2020. They're going to set the benchmark. Moving forward in 2021 and beyond, it's going to be related to the meeting of the previous year's MIPS scores. And so that's going to be fluid year by year as to where you go. If you are below the threshold, you'll have a negative payment adjustment. If you are above the threshold, you'll have a positive payment adjustment. Now, this is a budget-neutral endeavor. So everybody who is under the threshold, that's going to be the fund of monies available to those who are above the threshold. And in the first year, it's up to a 4% swing, positive or negative. Now, the one thing you want to keep in mind is if the threshold is, for instance, set at 50, and you score 51, you don't get 4%. You probably get 0.025%. It's a sliding scale as to where you're going to get. So if you're just a little bit over the threshold, you'll get a bump, but it's going to be a small bump. And the same thing, if you're under the threshold at 49, you're not going to take a 4% hit, but you are going to take a small payment adjustment in the negative. And they also put an additional provision that says for those extremely high performers, for those individuals who are above the top decile, they're at the top of the top, there is the potential. And again, this will be based on the budget, and this will be based on the funds available, and this will be based on decision of the Secretary. But again, the funds have to be distributed because it's budget neutral for up to a tripling effect. So for the few around the country, if you are at the very top of your overall composite score, it could be up to a 12% adjustment in the first year, and theoretically up to a 27% adjustment moving forward. So that is there, and that is provided. There are exemptions as to who must participate in the MIPS program through the fee-for-service pathway. So if you're in your first year of Medicare, accepting Medicare assignment, you do not have to participate. Now, there's been some interesting questions around the country. What if I've been in practice and I join with another independent practitioner across town and we form a new group with a new tax ID number? Does that exempt me? Or what if I sell my practice and I go to a system and I now have a new tax ID number? Does that exempt me? And the answer is no. Medicare follows your participation by your NPI and not your TIN. So if you can change TINs in 2019, but if you've been a Medicare provider for 30 years, you're subject to MIPS. If you're in an eligible alternative payment model that is going to receive the 5% bonus for any of your monies that you get in a fee-for-service arrangement through Medicare, you will not be subjected to MIPS. And then if you're below the low volume threshold, so if you are less than 10% or you're less than $10,000 in Medicare payments and less than 100 Medicare beneficiaries that you care for, you will not be subjected to MIPS. And it does appear, although this is a bit fuzzy, it does appear that your Medicare Advantage population will count towards your total number of Medicare patients. That also has been brought up to say, well, if I participate in all Medicare Advantage plans and only have a few Medicare, does that count? And it looks like no. They're going to count all Medicare beneficiaries, be they in Medicare Advantage or not. This was the part that when in the early slide we said increase access. And this is the one that has many individuals in many large organizations around the country a bit worried, because it is very possible that access for Medicare patients across all specialties, not primary care, just across all specialties, may decrease, because as things go with MIPS, depending on performance, we may see more and more physicians start to opt out of accepting Medicare assignment. And so this is something that I think is of importance, and something that I know the Academy is definitely going to address in their recommendations. So some additional real positive news here. If you're at your threshold, you have a stable payment. But if your performance score is at the 25th percentile or below, so you get your composite score and it's at the 25th percentile or below, it's a 4% hit in the first year, 5%, 7%, 9%. So you get the maximum penalty. So you want to make sure your composite score is at least above the 25th percentile. Are we having fun yet? All right, we'll keep going. So the timeline, I think we all know the timeline. We're in our baseline period right now. It's going to initiate in 2019. There are no positive updates to the Medicare physician fee schedule between 2019 and 2025. That's during the bonus period. And that's if, so there really is no, if you're in a qualifying APM, there's no upside. 2026 and beyond, you have additional positive payment updates. 0.25% if you're in a non-qualifying APM, and 0.75% if you're in a qualifying APM moving forward. So in summary, it consolidates the MIPS into a composite performance score, all of our existing programs, as well as adding a clinical performance improvement activity. It does provide for positive payment adjustments over the next several years, but definitely there is the risk of the payment penalty if the performance is below the threshold. So let's talk a little bit about APMs. And when the law came out, it looked like it was going to be pretty straightforward, and this would be the part of the talk that would be just pretty straightforward and easy, and we'd spend a couple minutes and go to questions and answers. And as it turns out, the proposed rule kind of muddied this up right along with it. So our definitions, you have a qualifying alternative payment model, and it's based on existing payment models. So again, think something along the lines of PCMH and some of the current ACO arrangements. And then, in order to be eligible for the bonus, you have to be in an advanced APM. So that is going to be based on the criteria of your payment model. So it's not just that you're practicing in a recognized PCMH, it's how are you receiving your payments within that PCMH. And then within that practice, you have to have your qualifying APM participants. And these are either individual participants, individual physician payment, or your volume that meets additional criteria to be eligible for the payment model. So again, they've created, and I'm going to show you in a moment, basically a Venn diagram as to how are you going to be qualified to be an advanced APM. So the ones that have been called out, Medicare shared savings programs, the demonstration projects, anything expanded under the CMS innovation model, some of the acute care episode demonstrations, those have all been called out to say they are qualifying APMs. Now, to be an advanced APM, you have to have your quality measures that are comparable to the MIPS quality measures. That doesn't mean they have to be the same, but you have to be tracking quality measures similar to PQRS, be reporting on that, be acting on that. You have to use a certified EHR technology, and that you have to accept more than nominal risk in your payment structure, or you have to be a medical home model under CMMI authority. So again, this is another place in the law where primary care through the patient-centered medical home, through the medical home model, is being called out and put into a separate pathway. Now, what's the definition of nominal risk? We don't know. That has not been defined. We think that's going to go ahead and come to us in the it will come to us in the final rule. I will say that your Academy board had a chance to have a conversation with Interim Secretary Slavitt, and we floated the idea that $1 was not greater than nominal risk. He just kind of laughed and said, no, that wouldn't be it. So we're not really sure yet what that definition is going to be, but it is definitely moving forward. Now, there are some programs that in the proposed rule have been called out as automatic qualifiers. So if you're in one of these models here, you automatically qualify as an advanced APM. So that is the Medicare shared savings programs, all three tracks. The next-gen ACO models, Track 2 and Track 3. So Track 2 and Track 3 of the ACOs. The end-stage renal disease, comprehensive care, the oncology care model, and the one that I think has had everybody, perked up is around CPC Plus. And we know that that is coming. We're expecting the 20 markets to be announced here this next month. And have the ability to sign up for those. So that is whether you're in Track 1 or Track 2 of CPC Plus. And remember, Track 1 and CPC Plus is not a huge risk. But if you're in either track, that'll be an automatic qualifier moving forward. So if you're not in one of those called out models that is an automatic advanced APM, how do we know if your current advanced payment, alternate payment model that you're in is going to qualify? Well, it's all related to the percentage of your patients that you receive payment for or how you receive your payment. 2019, that threshold is you either have 25% of your Medicare payments coming in a greater than nominal risk situation, or 20% of your total patient population through commercial payers and or Medicare are coming to you through some sort of risk-sharing model. Now, that can be at the group level or the individual level, either one. Most are going to make it at the group level to account for fluctuations in patient volumes. So if you qualify as a advanced APM, you're not subject to MIPS for any of your payments that are going to come to you from Medicare through a fee-for-service arrangement. You are eligible for a 5% bonus, and that's 5% of your total Medicare billings for the year through Part B will come to you as a bonus from 2019 through 2024. And then you have the higher fee schedule update that we had mentioned starting in 2026 and beyond, the 0.75% increase. So in summary, we are taking qualifying APMs that have been defined by the law, and now the proposed rule has created the advanced APMs that have to meet the further criteria. And then you have to be a qualifying participant within that APM in order to qualify for the 5% annual bonus and not have a downside. So that's really clear, right? Everybody's got that? So if we, again, just trying to walk through it, and this is something that I think is at least a beginning tool to start to look at. So you have to ask yourself the question, am I going to be eligible? So first off, am I in a qualifying APM? Do I practice in a PCMH? If the answer is yes, am I in an advanced APM? Meaning, am I either in CPC Plus or is my PCMH in an ACO model, Track 2, Track 3, that meets all the criteria of volume of patients or percentage of payments that's coming to me? And if it is, congratulations, you're there, you're ready to go. Now, again, straight from CMS, the estimate of the number of physicians in this country that are going to be in this first box right here on this algorithm, 5% in 2019. When you really look at it, they only anticipate 5 to at most 10% will be ready to go. Am I making your day? Good. But if you are not in an advanced APM or you do not have enough payments or patients to qualify as an advanced APM, then you are going to be subject to MIPS. However, you're going to get the favorable MIPS scoring around the clinical practice improvement activities. And then if your APM is participating, you're in a Medicare Advantage plan, whatever, where you're having some upside quality dollars, you still are eligible for those. You still get to receive those. So if you're on the other side of the algorithm, you say, no, I'm not currently practicing in it. Are you in your first year of Medicare, truly in your first year of Medicare, or do you have very low Medicare volumes? Then obviously you're not subject to MIPS. But if neither one of those applies to you, you are. And so this is a little algorithm to kind of help walk you through it. Again, the timeline, we've talked about this. It's there. The one thing to notice, though, is if you look at 2017 and 2018, PQRS, value-based modifier, meaningful use. If you are not reporting, if you are taking a hit on your value-based modifier, you theoretically have the chance to have up to a 9% penalty in 2017. So that's even before MIPS has started. That's just with the existing programs. And so I think that's something that, we're talking about MIPS and the sky is falling. And again, I think we don't want to play in MIPS if we can help it. That's personal opinion. But I also want to make sure that we're cognizant of the fact that, there are penalties out there for us right now with existing programs. So at the end of the day, we can say that the move to volume over value is definitely upon us. Final regulations, again, will be due out. The final ruling will be due out later this year. It's been stated all along that the benchmarking period, the 1 year of data they're going to gather on all of these various programs for MIPS is going to start January 1 of 2017. So that is coming up very, very, very soon, less than a half year away. I know there is a lot of concern from many, many specialty organizations that have been raised to CMS about what this represents to small practices, practices under 10, and this is all specialties. CMS is estimating that those practices with numbers of less than 10 physicians are more likely to be in the negative payment adjustment, at least for the first several years of MIPS. The law did allow for the formation of virtual groups. We didn't really talk about that, but if you are in a practice of less than 10 physicians, you can join together with other groups of less than 10 physicians to create a group of up to at least 50 in a certain region so that you can pool all of your quality and resource use and meaningful use data together to try to have strengthened numbers. So there are some options available, but again, that can be a challenging option, but it is there. So what should you be doing now besides panicking? No, I'm just kidding. Really, and I think most everyone in this room, and talking to you, I want to say I've been very impressed. Your awareness is very high. Most of you are really, and I'm just going to be honest, just speaking to you, I think most of you, in the way that you practice medicine and the way you're looking at quality and the way you're transforming yourselves, whether you're recognized PCMH or not, honestly, you folks are a bit more advanced than other areas of the country. That doesn't make it any softer for you, but just to let you know, I think a lot of these things that you're going to see on the slide, you're already doing. You know, are you submitting your PQRS? If not, get going, because that's going to be an aspect you're going to have to do. And have you reviewed your QRUR? And again, we have, I'll show on a slide or two, some good resource articles in family practice management about what that means and how to access that and how to review it. Have you attested for meaningful use? There are practice transformation networks out there. The Academy, matter of fact, just sent, I think everybody in your inbox yesterday should have gotten an email from them giving you the hyperlink where you can go to find out what are the PTNs in your network and in your state and in your locality. And again, these are many different organizations that have come together to really look at how can we help transform care. They have many of them different objectives. In some locations, they're as few as 1 or 2. Some states have, a half dozen or more. And so investigate what's out there, see if you want to participate, receive some of the help to try to help move this forward. And again, some of the resources that are online from the Academy currently. Now, I mentioned yesterday, and again, this is some more timelines, more resources. And I mentioned yesterday in the House of Delegates that the AAFP definitely takes this serious. I mean, this is, quite honestly, job one in terms of everything that we have on our plate. Our focus is this. And we have, the Board of Directors just this past 3 weeks ago authorized a MACRA implementation team. It's going to have 4 main legs. It's going to be around education, but it's also going to be around trying to enhance practice tools and try to ramp up the advocacy efforts with CMS to help this as much as possible. You're going to be hearing more of this moving forward. Sean Martin, and I think many of you know Sean or have seen Sean talk, he is going to be heading this. This is going to involve 37 staff around the Academy crossing 12 divisions. So this is something that the Academy recognizes. And I said it at the town hall personally. I mean, I think this is the piece of legislation that has the greatest impact on our practice of medicine since perhaps the Medicare Act of 1965. This is huge. And so we won't profess to have all the answers, but definitely this is a direction we need to go. So with that, I meant for this for me to go on for an hour, but to present the information, and I wanted to leave plenty of time for questions, and I will answer them to the best of my abilities. And if not, I will get you directed to who can answer them if there is. So.
Take one, two. Thank you very much for this very concise presentation. I think you boiled it down to these salient points of the macro. I just want to let everybody know that you spoke about PTN and help. Even though the government has thrown this at us, they've also thrown us a lifeline through the PTN program. In the country, there's about 23 programs that got funded. In New Jersey, we formed the New Jersey Innovation Institute. It's the former NJ High Tech, where we put 7,000 doctors in New Jersey on EMR, and we've now got the grant to do the PTM, which we call the Garden Practice Transformation Network, and that's available to 11,500 physicians who we have said that we would help transform. I am the CMIO of this, and if anybody has any interest in this, the website is www.njii.com/PTN. And it has all the information on there, the agreement that you can look at to sign up, and you'll be contacted. We have a team of now 100 people right now, a team of coaches that are being professionally trained in the PCMH model that will come to your office, do an assessment, give you some advice about how you can improve your ability to graduate into an APM so that you can meet all the either MIPS or macro regulations. So I want to let everybody know that in New Jersey, an NJIT got the largest grant that NJIT ever got, $50 million over a 4-year period of time to do this, and we're actually doing it across the country, but I really like to focus the attention of the resources to the docs here in this room, the academy physicians, physicians in various IPAs that are related to us, and I want to let everybody know that the New Jersey Academy of Family Physicians has a subcontract to coach another 700 doctors through this program, and Sandy Seltzer and myself will be in the lecture hall if you want to talk further about that.
Thank you for that, and I think that's absolutely great. I know my system in Kansas City, we signed up with a PTN as well. I think there is a lot of great resources, and absolutely, I'll just echo again, look into it, contact them, sign up. I think this is going to be very, very valuable as we move forward. Bob.
Mike, New Jersey has a very high cost of care for Medicare beneficiaries. In fact, I think we rank 50th on cost of care in the last 6 months of life or last year of life. And I'm wondering whether or not that's an opportunity or a threat or both. And my question on the QRUR and the utilization is, I understand that it's severity adjusted, but is it also regionally adjusted?
My understanding is yes, there is a regional adjustment to it. Definitely there's a severity adjustment to it as well. And so, yes.
I have a question.
Yes.
More about some of the details of reporting. But if you start reporting in 17 to MIPS, but in 18, you join an organization that's, an advanced APM, what do they do with the data from the MIPS? I mean, are you going to be able to qualify to participate in that advanced APM because you had once participated in MIPS in the year 2017? They got 18 seems to be like a dangling year.
Right, and the reason, well, I think there's a couple of reasons. I mean, number one, you've got 17, and the initial explanation from CMS is they needed a year's worth of data, and then they needed a year's worth of analysis. That's what they told us. But I think that also gives you, so in 18, theoretically, you're on the hook for 20. Okay, so it's always going to be at least initially a 2-year lag. But my understanding right now, and I will be honest, in the proposed rule, and again, I'm one of the really, really weird sick people, and I read through that. And I am not sure, honestly, in my mind, is if you go into an APM, at least my interpretation is, if you go into an APM on December 31st, 2018, then starting in 2019, you're in an advanced APM, and you're not in MIPS. But again, that's Mike Munger's interpretation, and it was 962 pages and boring. Yes, Peter.
Yeah, hi. This is a little bit of a setup question. It's the same question I asked at the town hall 2 nights ago, but we're in a group that's hoping to get into CPC Plus, and we have multiple office sites. And I wanted to clarify whether if one of the office sites gets into CPC Plus, will all of them be included, or could there be variations where some get in and some don't get in?
I asked Peter to ask me that question because I blew it on town hall. I just want everybody to know that I answered what everybody liked to hear is no, on CPC Plus, if you're in a system or you're in a practice that has multiple sites, it's going to be submitted based on your TIN, and everybody would be in. And then I got to thinking about that and went back and checked through CMS as well as the Academy, and the answer, unfortunately, is no. Your CPC Plus is going to be site-specific when you submit. And so the example that I've given a couple of individuals is, look, for myself in the Kansas City area, 5 of our offices are on the Kansas side and 13 are on the Missouri side. Theoretically, a region could be, and we don't know what the definition of a, quote, region is. You would think, oh, well, that would include Kansas City metropolitan area. Well, maybe not. Maybe it's Missouri and not Kansas, so 13 would go in, 5 would not, or vice versa. Or even if the entire metropolitan area is a region, theoretically they could look at half of the offices or a third of the offices and bring them in, and even though the application information would be identical, not support the others. So that's the latest we have on that.
Can I have a follow-up question?
Absolutely.
On one of your original slides, one of the goals of MACRA was to increase access for Medicare services by improving payments. It doesn't sound like it's achieving that goal if it's budget neutral.
And I agree. The answer you would receive from CMS is, but it does if you are in an advanced APM, because that 5% is not budget neutral. That is truly additional payment. That's not a great answer, but that's the answer you would get.
Doctor, a general question. Will the election of a new president have any effect on what you said today?
In terms of MACRA, no. Because it's been enacted, and the fact that it had such overwhelming bipartisan support and passed, 92-7 and 392-37 or whatever that was, there is absolutely zero stomach inside the Beltway in Congress to revisit this. As far as Congress is concerned, they've solved that. They want to move on. Now, we're facing a lot of different things through MIPS, but in their mind, we're not going there again. So,
I have a question about the CPIA with the Access, Population Management, Care Coordination. We are all competing for the same patients. So if we have patients that go to the hospital and I'm trying to do my transitional code and I have enrolled my patients in the CCP program, also the management, the chronic care management, now what I'm seeing lately is that a lot of the specialties that were involved in the care of that hospital patient, they are doing these things also. So when we enroll our patients, who gets tracked for this alternative payment model? The person that the patient signed first with, or what? Because a lot of the patients are ignorant about what they are signing. You have to sit down and explain. But what I'm seeing is that we have so much competition now. It's not like, I use my referral physician, this cardiologist, that pulmonologist. It's like a war out there that I never saw before.
Absolutely. You're absolutely right with the introduction of some of the value-based coding. And that extends to things like the annual Medicare Wellness Code. The number of non-primary care physicians and entities that are starting to drop that code is personally somewhat appalling. because that's meant to be a primary care code. That's a health risk assessment that we need to be doing. And so, but your larger question of attribution is huge, and that's not answered yet. I mean, so how do we identify who are your patients, or who's Rich's patients? And one thing that it does appear, and the best we can tell, is on the clinical performance activity. If a gap gets closed, if the care coordination happens, if the beneficiary has been sent, a CG CAP survey, be it from cardiology or you, when that gets submitted, anyone that's tied to that patient will get the credit for it. Same thing on the quality side. If for some reason our cardiology colleagues decide they're going to start giving Pneumovax, stranger things may have happened. But if that happens, then, it will close a gap for us on one of those cross-cutting. And so that's currently the way it stands. One thing we didn't really get into, and I didn't have in this slide deck, but is also starting in January of 2018, and this is especially around resource use. We all are going to have different buckets that we're going to be placed into. In other words, when we submit a claim for Medicare, we're going to have to identify which of the services are we providing for that patient. And they have the various, I don't remember the exact names, but one is like provides continuing ongoing care across all settings. Well, that's primary care. And one is takes the lead on acute care episodes, providing the primary care. That would be the hospitalist. And one is, provide only emergent care on a short-term basis. That's the emergency department. So they have all these various buckets, and that's the way they're going to identify in terms of the resource use. And kind of to Bob's question of is it going to be regionalized, but that's also how you're going to be judged, is you're going to be judged against other individuals in that reporting. And we're all going to have to start adding that to our Medicare claims starting January of 2018. So that's another layer that's going to be added to our claim submission so they can start to track for the year leading up of how you define yourself in terms of your resource use.
As a solo doctor, Medicare is only 15% of my patient mix, and the private payers pay me 30 to 40% less than Medicare. So I'm not sure that your Medicare cutting me 4 to 15% does anything to me. But my bigger question is, if they do that, will then my private payers cut me even lower? So there.
I wish I could answer that question. And again, this is CMS. You raise the issue of the next frontier in advocacy for your academy, and that is with commercial payers. And that's been challenging. We meet twice yearly with the top 6 payers, commercial payers.
Care.
And I'm not disagreeing with you, but I mean,
Medicare,
it's a strategy.
for them to be afraid, I'm sorry to interrupt, but for them to be afraid that the Medicare people aren't going to have access, I would love for all of you people to dump your Medicare patients, because I could finally make a little money. Mm-hmm. And so I don't think that there's going to be a lack of physicians.
I think
for that reason.
Well, and I think the thought is there's probably not going to be a lack of primary care physicians, but will there be a lack of subspecialty and surgical specialty?
Tom Shaffrey, past president, also congressional key contact for New Jersey, been going to the FMCC for a number of years. In terms of legislative reform, just to end on a note like this, I'd be very interested in anybody who would want to form a committee for grassroots legislation to pay our members of Congress the exact same way they're proposing to pay us. Can we have quality measures for our members of Congress? And I wouldn't mind taking back a little bit of their salaries. I mean, I'm okay with that.
I will definitely sign that petition and be with you on that one. Okay. Do we have any other questions? Or
Yeah, Mike, you had talked about small groups being able to tether together. What's the mechanism, and how do they find out about how to do that?
That, I think, is going to come with the final rule in late September, early October. We'll actually set up the mechanics on how that's going to work. It's only been out there in kind of broad strokes, but that's actually, we expect that in the final ruling to give the granular details as to how that's going to work.
Okay.
All right? Thank you very much.
Thank you, Dr. Munger. The sign-in sheets are over here in the front of the room to the right if anyone did not sign in. And please remember to fill out your evaluations in the conference app. Thanks.